Hello, everyone. I would like first to welcome you all to the inaugural webinar of the ILAE Young Epilepsy section that is focusing on basic and translational science. So this is an endeavor that was initiated by several groups, the ILAE Young Epilepsy Section, Translational Task Force, the Neurobiology Commission, and many other people that helped to promote the webinars, create the flyers, so shout out to all of them. Today, we are going to start with a very important topic that focuses on animal models of seizures and acquired epilepsies. We have a wonderful speaker, Dr. Cristina Reschke, who is going to give the inaugurate seminar. And with that, I'm gonna introduce you to our speaker. So Cristina is a lecturer in the School of Pharmacy and Biomolecular Sciences and funded investigator within FutureNeuro Research Center at University of Medicine and Health Sciences in Ireland. She trained as clinical pharmacist and holds master and PhD in pharmacology, which were focused on epilepsy treatment. Cristina's major discoveries are on microRNA-based therapies and the preclinical development of novel oligonucleotide delivery systems. She received a number of international awards, including the Harinarian and the Grass Awards, endowed by the ILA-NAS, and she is also the recipient of the Cure Taking Flight Award. Cristina's research focuses on uncovering cellular and molecular mechanisms underlying epilepsy to allow for the development of novel and precise therapeutic and diagnostic approaches. Specifically, she is interested in the chronobiology of epilepsy. Cristina serves in a number of ILA task forces and is the past global treasurer of ILAES. Nationally, she is the academic member for the Irish Epilepsy League Council and the academic director for the RCSI International Citizenship Program. And with that, and no further ado, I would like to welcome Cristina, and I look forward to your presentation, Cristina. And for the discussion part of the webinar, please feel free to ask your questions in the Q&A button at the bottom of your screen, and by the end of the webinar, we are going to have an interactive discussion. Thank you so much.
Thank you so much for the kind introduction, Christos, and welcome everyone. It's a great pleasure to be here. Thank you so much for the invitation, and I feel extremely honored to open this webinar series, and I really hope that you're going to enjoy it, not only the talk today, but also the upcoming lectures that you have. I believe you can see my screen. So just as disclosure, as Christos mentioned, we already had prepared all this material as part of a teaching course for the International Epilepsy Congress that was held in Dublin a few months ago. And I'm going to bring up the learning objectives of this, not only of the webinar today, but in a broader way, what we expect to discuss in the coming weeks as regards the use of animal models and epilepsy. So we would like that at the completion of these webinars in animal models, you're going to be able to understand the need for the use of animal models in epilepsy research. It's extremely important that we discuss it further, to have an overview of the models for specific types of epilepsies, to understand how different models can mimic different types of epilepsy, to describe major uses and limitations of commonly used animal models, and to select the appropriate model to address a specific research question that matches with your research. So this would be the overall learning objectives. And when we progress to the outline of the talk today, so what we would like to cover, and since now I would like to encourage you to ask questions and to start thinking about your models. So let's start with, why do we need to use animal models in epilepsy research? What will we model? So what actually are we modeling? What are good models? And then we're going to look at some examples and how to model, especially as the main focus is the seizures and acquired epilepsy, and what we have to consider in our experimental design. So to start our discussion today, I would like to bring the first question. So what do we need to use animal models in epilepsy research. I will bring to you in a minute the reasons why animal models are so essential in our current scenario. However, I also would like to bring something that we step back a little bit from the models themselves, and we look what are the first questions that we have to ask. And one of the main concepts that come when we are thinking about modeling, not only in epilepsy research, but other fields, we come across a lot with the 3 R's. So the 3 R's are the replacement, reduction, and refinement. And these actually have been proposed a long time ago in 1959 from the book of Principles of Humane and Experimental Techniques. So the idea is that we are going to, first of all, assessing our questions and assessing whether we can replace the model. Is there actually a possibility of avoid the use of animals to address these research questions? So this is the first point that we have to look whenever we have a research question. So from the development in 1959 to what actually we are looking towards modern research, especially modern neuroscience, we not only think in the basic concept of avoiding and replacing the animals, but actually we can look at a more up-to-date view in that concept. We can think about what else can we use to accelerate and develop, what are the tools available that can support our research and accelerate the discovery that actually maybe could avoid the use of the animals, or could come across to the second step that would be to reduce, to minimize the use of animals, still keeping consistency with our research aims. So the second moment would be, okay, we need to answer this question. We need a model that has been established, and we're going to see a number of very important reasons why we do need them in research. However, we always keep in mind the need of minimizing the number. And one thing that I really do like to touch today when we're looking at the models is as regards the experimental design, and how can we actually appropriately design our experiments to ensure that the use of those animals is extremely valuable, to ensure that we have a robust and reproducible data that will actually be true to generate the knowledge that will be translated later on and is going to be useful to progress science. So this is the actual reduction that we want. Last but not least, it's important that we keep in mind our refinement. And this refinement, each institution that works, I'm 100% sure is well equipped with not only staff, but facilities and support in order to minimize the pain and the suffering, the stress that these animals undergo when they are research subjects. However, we also have to think that extra refinement and advancing the welfare and exploiting from in vivo technologies that are available, that will actually not only generate the refinement that is required, but also will be bringing extra confidence and reliability in our data. And this we're going to be looking at a little bit further in a moment. So animal models, as I mentioned, they are essential for drug discovery. They're essential for the development of therapeutic monitoring, development of diagnostic and tools in a general way. So they are extremely important for the discovery of new anti-seizure medications, for the discovery of disease-modifying treatments, and the characterization of the activity spectrum of all those treatments. They are extremely important also because it's only through the use of the models that we can estimate the pharmacokinetics and pharmacodynamics that will support the translation of our research, that is going to ensure also safety and efficacy, and is going to allow for future therapeutic monitoring of that treatment. Also, it's extremely important because through the animal models, we are able to reliably investigate the adverse events that we possibly can have, and we can already mimic what we expect to see in humans, and also to understand a little bit more about drug interactions. So we're going to also need them to understand pharmacoresistance, and we have a number of models that actually mimic the pharmacoresistance that we currently have in epilepsy. That is one of our challenges in therapeutic, and also support the changes in efficacy that could happen at a chronic stage. So long-term monitoring of those animals will allow us to have a more longitudinal view in that aspect. So the animal models are not only from the therapeutic perspective, but actually they support us to understand the disease mechanisms at different stages of the disease and at different aspects of the disease as well. What is key component for the development of precise therapeutic and diagnostic tools. So it also supports the possibility of stratify a disease, especially in epilepsy, what is extremely relevant because of the complexity of the disease, and this will support further therapeutic and diagnostic development, and also for the discovery of novel biomarkers, which could be useful for the monitoring of the therapeutic, but also for the diagnostic purposes. So now we know that we need these models, and research is extremely important, and we rely on them. So, but what will we model? So the overall focus on that we have is on mimicking seizures, or mimicking epilepsy development, epileptogenesis, or also we could be focusing on the chronic stages of the disease. So here we have to establish, depending on our research question, what is our focus. However, although this is a very simplistic way to look at focusing in each one of these stages, it's way more complex. And in order to fully address translation and to be truthful to moving basic research towards translation, we need to have we need to address the needs from the patient side. So we are bringing from the bed back to the lab, and again bringing back to the patient. So discussions evolved over the past years, a lot of discussions around what are good models and what is the major reason, the major reason for this debate is trying to close this gap of translation between preclinical and clinical side. So because we really want to have systems, we have to allow for the developments of systems that will be very well standardized and could be clinically predictable with high throughput screens, and that will bring a prospective new anti-seizure medication or a prospective drug that could modify the disease. So the model needs to fit the purpose and not only look at the expected activity, but also needs to support the understanding of the effective, for instance, not only the efficacy, but also has to support the understanding of the drug plasma levels, the adverse effects, how this is going to act on comorbidities. Also, we need to understand a little bit, support the understanding of the mechanism of action, target engagement, and so on. So these are very important points that we need to keep in mind. So what are good models then? I think it's very important here that I start disclosing that unfortunately, I'm not going to be able to answer this question today. However, I'm here to actually foster the discussion and bring more questions. So I would like that you would be thinking about what are good models to yourselves, and that we start critically thinking about the models, the examples that I'm going to bring here today, and also the examples that colleagues are going to be bringing in the coming weeks. And when you think about your own research questions, so what would be a good model to you? So briefly, the discussion would arise around two main approaches that we could be looking at. The first approach would be referring to the analogical model. I think that many of you already have heard that the best model for a cat is the same cat. So this is an idea that was proposed back in 1945, and it really refers that we need to model in a more complex way. We need to model the disease in order to understand. So this approach contends that the more an animal's condition resembles the human epilepsy, the best is the model. So we really would like to seek for the full resemblance of the disease in order to have it as a good model. On the other hand, we have also the possibility of thinking a more conceptual idea with the conceptual modeling, which brings the idea that is not only about the resemblance, but also about the processes. So here I bring an example of the second approach that is very well embodied by the painting from René Magritte that shows a pipe. So we have a figure of a pipe, and that is followed by the phrase, "This is not a pipe." So this is actually not a pipe, this is a figure. So it's not about the resemblance, but also to reproduce the process of interest. So here we're going to be talking about, in a more simplistic way, about the processes. And here we're going to be talking about the overall, the disease with in a more complex way, with the all complexity that we have. So what are good models in this sense? There is no right or wrong in this discussion. So both of them, both of approaches, they're only different approaches. And it's extremely important that we think that one is going to complement the other. So again, it really depends on the research question that we are seeking. So here we're going to be looking at modeling the disease, and here we're going to be modeling more the processes. So how will we model? So to model here, we're going to keep as didactic as possible. I like to adopt this schematic from Leischer's article that shows an overview of the model of epilepsies and epileptic seizures. The genetic side is going to be discussed next week by Professor Henschel. Here I'm going to be focused on the induction of seizures and the acquired epilepsy models. So we're going to take a look a little bit more into detail. And let's start focusing on the acquired, the acute model of induction of seizures. So focusing here on the acute process. So here we are focusing on the process, we're focusing on the symptom of the main symptom of epilepsy, that are the occurrence of seizures. And we can induce these seizures in an acute way. So very briefly, the most common ways of inducing acute seizures are going to be either by electrical stimulation or by chemical convulsants. So here I bring examples of, for instance, the MES test in rodents, that is the maximum electroshock seizure test, or the 6-Hz electrical stimulation. So true electrical stimulation is going to induce the seizures. On the other hand, very widely used chemical convulsants are the pentylene-tetrazole, that can be used not only in rodents, but also there are models in zebrafish, and the cyanic acid that can be used as well to induce acute seizures. So let's take a look into a little bit more of detail. But here again, I wanted to disclose that these are is a non-exhaustive list. So we're just bringing some examples in order to bring the discussion around the concepts. So in the model of the maximal electroshock seizure test, the MES model, it has been developed to model generalized tonic-clonic seizures. So there is generally an application of an electrical stimulation via the transcorneal or the transauricular electrodes. So, and differences in currents are applied for either mice or rats. So they have fixed currents of usually 50 milliamperes for mice and 150 for rats. With a 56 Hertz pulse of frequency and 0.6 millisecond pulse width and 0.2 seconds of the stimulus duration. So you have an acute stimulation of this electric current, and the endpoint that is going to be observed is going to be the tonic extension and the posterior extremity. So whenever we reach the tonic-clonic component. So here usually there is a pre-treatment of the pharmacological, the therapeutic test for the therapeutic drug that is going to be tested, and there is the use of the model in a very simplistic way. So when we move to the chemoconvulsants, one of the most used models of to induce seizures is the pentylene-tetrazole, which is a GABA-A receptor antagonist. So usually upon administration of pentylene-tetrazole, there is an observation period of about 30 minutes in general. So this model is commonly used to induce clonic or tonic-clonic seizures. However, it's something interesting and important to bring here, and this is not only valid for pentylene-tetrazole, but for other models of other chemoconvulsants as well. So depending on the dose that we're administering and depending on the route of administration, we are going to have different effects, and we can observe different types of behavior. For instance, here it's really important that pentylene-tetrazole upon injection is not going to trigger only one type of seizures. However, there is a known 4 behavioral phenomena that is going to happen that starts with freezing and then moves to myoclonic twitches, clonic seizures, and finally the mice or the rat develop tonic-clonic seizures. Here is the importance of the concomitant electroencephalographic recording in this model, because to capture especially movements like freezing and the myoclonic twitches is extremely important to be accompanied by the EEG. So the administration usually is done systemically in a dose that ranges in general from 50 to 8 milligrams per kilogram. So this systemic could be either subcutaneous, IV, or mostly used intraperitoneal administration. So the CD97 for pentylene-tetrazole, that means that it causes at least convulsions of at least 5 seconds in 97 out of 100 animals, would vary between mice and rats. So here for the acute seizures, in a general way, we are talking about a chemoconvulsant, but that's also valid for other acute models with electrical stimulations, for instance. What we're looking at as readout and output, and that's something important to think, is that we are going to be looking at, okay, what's the seizure onset upon administration in this case? Does my treatment increase or decrease, changes the seizure onset? What is the associated behavior that we have, as here commonly measured by Racine scale? That could be the usual Racine scale, or could be the modified one, depending on the model that I'm using. So what is the convulsion duration? Does the treatment reduces or changes the convulsion duration? And also, what are the other measurements and readouts that I can have from the electroencephalographic recording? So in this case here, we have a picture, the EEG total power. That is a measure of seizure severity that actually accounts for amplitude and frequency. So we can see that in this case, the treatment reduces the seizure severity as measured from the EEG power and compared to the animal on baseline. So another relevance of the use of the EEG in this model is that when we can investigate the use, we can investigate the presence of rhythmic spindle-shaped discharge, as you can see picture here in this representative figure, which would, and also the crescendo and decrescendo pattern. So this would characterize the freezing behavior that easily would be missed if it would not be accompanied by EEG recording. So moving from the modeling of acute seizures and moving to how to model epilepsy. So here we are talking about models of acquired epilepsies as you can see in the diagram, I'm not going to be talking today about the kindling models. So I'm going to be talking about the acute seizures and also about models that we can have the development of epilepsy after the triggering of the status epilepticus. But again, it's extremely important to think the development of epilepsy itself is very, very complex. And we have a number of initial events that could be actually triggering the development of epilepsy along the way. So here, in these models that we're going to be looking at, and the most commonly used models, they actually trigger epilepsy through the development of status epilepticus. However, we have models, for instance, for trauma, for post-traumatic epilepsy that we're not going to be covering today, that have different initial insult, initial trauma. So I bring this schematic because here we can see that we have the concept of epileptogenesis. So we have this initial event that it could lead to the onset of epileptogenesis and a number of functional and structural brain alterations that will make this brain more prone to develop a late and chronic stage that are the spontaneous and recurrent seizures that we have. So that would mean the established epilepsy in the case here in the animal. So we have different possibilities of interventions in this process. So the most obvious intervention, especially when we talk about clinical relevance and translation, is that we're going to be treating epilepsy. So we have epilepsy already established, and we would like to do an intervention to either reverse the phenotype that we have in that is already established in the animal model, or we are going to be looking at decrease this phenotype and modify the disease at this later stage. So this is one of the obvious aims here. However, we can have interventions in our animal models at different stages that at first glance is quite difficult to understand, okay, how it's going to be the potential for translation. However, these are events and processes really important because we're going to be understanding in depth the mechanism of the disease, and by the understanding of the mechanism of disease will in the future allow for interventions that could prevent epilepsy development. So we can either in our animal models, for instance, do an intervention that is going to be right before the status epilepticus that is already known, that is already established in the model, or we can do an intervention soon after the status epilepticus to see if our therapeutic has potential to prevent epilepsy development, to change epileptogenesis and prevent epilepsy development here. So modeling, as I mentioned to you here, focusing on triggering status epilepticus in order to model epilepsy. So again, we have two main ways of doing it in a general way. Would be again via electrical stimulation or by the use of chemoconvulsants. For instance, I'm going to briefly touch the example of perforant pathway stimulation and widely used models, for instance, the use of canic acid that has a number of route of administrations that we're going to be talking in a minute, and also the use of pilocarpine that today I'm not going to bring here, but is also widely used as a chemoconvulsant for the study of epilepsy. So in the case of electrical stimulation, for instance, the perforant pathway stimulation is a model that is commonly used in rats. And upon the surgical procedure that it will implant electrodes in the perforant path and electrodes for stimulations, and when an electrode that is going to be implanted usually in the hippocampus for recording of the EEG. So we have usually the stimulus, the common protocol is with the stimulus over 3 consecutive days. The first day we're going to have 30 minutes of stimulus, the second day 30 minutes of stimulus, and the third day 8 hours of stimulus. And then we are going to have your epileptogenesis process here. So in this case is around 15 to 25 days until these rats start developing spontaneous recurrent seizures. So here is one thing I would like to take your attention when we're talking about the models, because we are going to have different latent periods, different times where between the stimulation or the injection of the chemoconvulsant until the establishment of epilepsy. And this latent period is going to vary across the models. So this is all, again, it's important to really understand what are we modeling and how these differences actually are relevant in order to use different models and ensure or increase the possibility of translation. Another model that I would like to bring is the intramedullary acid model. So I already mentioned about the use of canic acid, that is a glutamatergic agonist. So briefly in this model, it's been used in either rats and mice, but here I bring the example of the use in mice. So there is the electrode implantation, and a guide cannula is implanted to allow for the injection of canic acid directly into the amygdala. In this model is a unilateral injection, and this will trigger a status epilepticus, and usually it's commonly used lorazepam to reduce mortality and morbidity at 40 minutes after the injection of canic acid. And at 24 hours after status epilepticus, there is a feature that is a damage in the hippocampus, the ipsilateral hippocampus of these mice. What could one could argue that mimics the damage that you see in temporal lobe epilepsy. So in this model, mice will develop spontaneous recurrent seizures from 3 to 5 days after the triggering of the status epilepticus, and these seizures will cluster over time in an average of about 7 seizures a day, depending on the day post canic acid injection. So what are the variations of the same model? And here is the point that I would like to make. For instance, this study that was published last year shows the exactly same model, that is injection of canic acid into the amygdala. However, instead of lorazepam to curtail seizures, there is the use of midazolam, and also there is the test of using no seizure curtail here in this case, in the injection of saline. So it's interesting to see that they have seen no difference between using or not using midazolam, for instance, in the model. And also here they followed the mice for several weeks. And as you can see, the number of seizures, the seizure frequency per day is a little bit lower than what has been seen before. However, it's still quite similar in this sense. So one thing that is important here, and I bring this differences in the studies, is for us to think that all the differences that we have in the labs, the biological differences that we're going to have, for instance, we're talking about different mice strain, we're talking about different sex, different conditions in the lab, different differences in animals' facilities. For instance, some facilities are going to be pathogen free, some facilities are going to be cleaner than others. So we have a number of things that could influence that the same model that could be performed with the same even with the same the same way could still have variability. So I bring this because it's really important that sometimes when we have the model in the lab, we are bringing a new model in the lab, that we do a full characterization in order to ensure how the model that we would like to establish is working in our hands and with our conditions, in order to ascertain that we are going to have a reproducibility in the future. So then, are canic acid models all the same? So in my answer, I would say my short answer would be no. but all of them, they mimic spontaneous recurrent seizures. So we have a number of different ways to inject cyanic acid, as I mentioned. So I brought an example of the injection of the intramedulla. However, we commonly see the injection of the intrahippocampus, and then that's going to give us a different pattern of seizures. The number of seizures per day is going to be different. The type of seizure that you see is going to be different. Also, we're going to see differences in other pathological traits of the disease, for instance, the comorbidities, or histologically speaking as well, we could have differences here. So commonly, here you can see that could be administered systemically, could be administered not only intrahippocampus or intramedulla, but also in the ventricle, or it can even be administered intranasally. So the route of administration that we're going to be choosing will actually impact in the effect that we have and the phenotype that we have with the model. And that's important to think. For instance, if we have the systemic administration, we still have to cross the blood-brain barrier, and the time that is gonna, and the time and the pathway that is gonna do until reach the brain, and we can have the action actually activating the glutamatergic pathway and the kainate receptors. It's gonna take longer than the ones that are gonna be directly administered to the brain. So there are advantages and disadvantages of each one of these route of administrations, and some of them are less invasive, some of them are more invasive. Some of them are going to have a higher variability than others. Some of them are going to have higher mortality rates than others. So again, it's always extremely important that we think what actually is the question that we want to answer in order to prioritize and choose the right model. So finally, so what do we consider in the experimental design? So I already mentioned about some of the factors that could be impacting the experimental conditions. So key factors that could be impacting, for instance, the biological, different species that we have, different strains. Sometimes we have seen already mice from the same strain that come from different suppliers, and they itself could trigger differences in phenotype in the model. Differences in sex is extremely important to look at males and females and consider all the related cycles, for instance, the hormonal cycles. Differences in age, for instance, not only talking about the immature brain and the mature brain that we're going to be focusing on different aspects, but also the aging brain needs to be considered, and how for instance, the inflammatory processes are happening physiologically, what are the changes in this aging brain that are happening, and also the blood-brain barrier scenario with the aging brain and all the changes that come needs to be taken into account. Body rhythms as well is extremely important. We need to consider technical factors, as I already mentioned, not only the laboratory temperature, humidity, but also the exposure to light and dark cycles and how that could impact. Pharmacological, the drug formulations that we have, not only the drug formulations in the case of using, for instance, chemoconvulsants, but also for the treatments that we would like to test in the case of therapeutics. And when we look at in our experimental design, we need to check what is the type of seizure intervention that we are looking for. So what actually we are looking for to obtain. Are we looking at a process? We'd like to mimic a single seizure. We'd like to mimic a more complex state with the comorbidities, to look at disease modifying treatment, to look at seizure prevention. So what is our goal to define the seizure intervention? And then knowing our model and knowing what to expect, we can either go, for instance, okay, will we do a pre-treatment with a drug, and to see if this pre-treatment is able to modify the expected intervention, or are we doing an experimental design where we have the seizure intervention and we have a post-treatment where we're going to be looking at epilepsy development, or even at a later chronic stage that we're going to be looking at the reversing the phenotype or modifying the disease. And last but not least, is extremely important to think of our outputs and what we want to measure from this experiment, and what are the readouts that we have in order to ensure that we assess it as the best way possible. So as my taking home message to wrap up before our discussions, I just would like to bring again that we have different types of models. There are no extremely good or bad models, but all models answer different questions. And it's extremely important for us to progress translational research that we focus on the questions relevant from the patient, bring back to the lab, and then ensure that we can progress with reliable results. We can progress and move towards translation. So with that, I would like to acknowledge, to thank you very much, you all. I would like to thank for the invitation from YES, especially the YES Research and Translational Task Force for organizing these webinars. All the YESs across the world. I'd like to thank everyone that came to Dublin for the ISC. It was a pleasure to see you here. And the support from the Neurobiology Commission and the partners from the 4U Plus for the development of this content. Thank you very much, everyone, and I'm very happy to take your questions.
Fantastic talk, Cristina. We learned a lot. Thank you so much.
Thank you.
So everyone, please feel free to ask your questions over the Q&A box, and we're gonna answer them live. So we have questions already. So great talk. They are starting to work with animal models of pharmacoresistant epilepsy, and they are interested in focal seizures of the temporal lobe. The focus of the analysis is on the ictal phase with electrophysiology and spectral mathematical analysis. So they have some very exciting results in humans, but they want to apply their analytical approach in animal models. And they're asking which model would be best to use.
That's a very good question. So Christos, you jump in, and everyone that would like to jump in. So it's really interesting to see what's the best model. I would say when you're interested, like, you know, in studying pharmacoresistance, the first question that I would actually ask, and to see, okay, narrow down the models that are available. Do a very good literature search to see the models that are available, and check which ones actually present pharmacoresistance, because not all the models will present pharmacoresistance or will present different levels of pharmacoresistance. So how do you characterize that? And sometimes we have differences across labs again. So it's important that you take what are the key the key concepts of pharmacoresistance, and how you and test in your model before you start. I think that's a key point, I think would be extremely important. I think it's very good that you're moving from human EEG data and bringing and doing this approach from the patient back to the lab to inform again. However, it's like to choose a model, I would be very biased to actually infer on a model.
Yeah, I echo Cristina's answer, and you know, it's always good to have more than one model to see if results are, you know, generalizable. So the other question is, looking at the different ways to induce the models and the different approaches, they may affect different epileptogenesis processes. How far do you think it may help to recapitulate the essence of epileptogenic process actually occurs in humans? If so, can you suggest in your experience a model that better captures the analogy of epileptogenesis in humans, apart from kainic acid and pylo, to reduce translability failure?
That's a very good question, and I think like the question is way broader and more, and there is no one answer here. So I can share my thoughts, and I would say would welcome everyone's thoughts on that. But I think epileptogenesis itself is extremely complex. If we think about epileptogenesis in humans, is extremely complex. We have a number of different causes that could be triggering. We have, from genetic perspectives, we have a number of insults to the brain that could be triggering. And all these changes that are happening, they are not isolated. They're not. We cannot pinpoint, okay, this is causing by it's a metabolic type, so this is causing by, because you have all the other factors that are going to be there contributing. You're going to have genetic predisposition, you're going to have age, you're going to have all the epigenetics, you're going to have a number of other components that must be considered. This talking in humans, and that's one of the things that makes epilepsy so complex. And we have this high complexity, and that makes very, very difficult to actually understand what makes a normal brain to become an epileptic one. So back to the models, in my opinion, we have a number of models that address here. For instance, I brought examples of models that actually use the status epilepticus as a trigger, and using status epilepticus as a trigger, but again using different processes that are different. For instance, you have one that is going to be chemoconvulsant, another one that's going to be for electrostimulation. So it's, I would say, clean in that sense. So the idea of using as many different models with different that triggers from different ways, you likely have a more reliable result. But again, we are just focusing on one type of epileptogenesis, if you like. We are not. We still have. We are in a cleaner environment with the animal models, and we still can't have like the full complexity. But yeah, I would say aiding. We're not gonna. In my opinion, we're not gonna aid all epileptogenesis. It's like we really need to focus in the different types of epilepsies. And I think comes again with patient stratification. And if we are able to focus even more in patient stratification, that's going to help us to develop better, more precise therapeutic approaches and diagnostics, therapeutic monitoring. And for our models, I think we actually need further stratification to actually identify exactly what we are mimicking. But triangulating and trying to get to different processes, I think that kind of increases your chances that the effect that you're finding is going to be translatable. So Chris is happy to.
No, you covered what I was thinking too. Another question that I have is you beautifully showed the models of acute seizures and the models of chronic epilepsy. And I'm very curious, based on your experience with microRNAs and the cycles. So the interventions that you see when an animal has an acute seizure and you see, an effect, and then you go and you are curious to see what happens in chronic epilepsy. How often do you see the same thing, or you usually don't see the same thing? Is it in contrast? So what is your experience on that?
I think it's very variable. It's like it really depends. If you're talking about acute in the sense of using pentylene tetrazole, or acutely using the same model. Okay,
it can be different models also.
Yeah. I have to say that in my opinion, I think there is a lot to do with the drug that you're testing in that case, the properties of the drug. And that's important to know exactly when you're testing something, exactly, to know as much as possible about what you're testing and the pharmacological properties of that. So I think that rarely a drug is going to work for everything. And we do not want anymore fit to all purpose. We want something that's going to be more and more precise. So I wouldn't expect that my drug is going to be working across all types of models and all types, because at the end, we're going to end up with what we already have, that are anti-seizure medications. Not that we do not need those type of drugs. Anti-seizure medications are extremely important. They work. However, what we focus is really trying to, so I wouldn't say that not necessarily they will work. In my experience, some of the drugs I've tested, for instance, with microRNA with ancestral oligonucleotides, some of them, they worked across a number of acute seizures and chronic, but didn't work in genetics when we brought, for instance, to genetic models. Others would, it really will depend, I would say, on the property of the drug.
Yeah.
But for us, I think like working as with the industry as well, one of the things that you start your search in the simple, and then we move to the more complex. So I like the idea of testing my drug in a kind of pre-screening, and the NIH also has a very beautiful pipeline, the ADD program as well, that we start, seeing, okay, if it works in the pentylentitrazole or the MES, and then you progress as a pipeline for the next steps, because then you're going to be using likely more mice. It's going to be more difficult to design the experiments. It's going to be more expensive. So there is this idea of progressing from one model to the other as well.
Thank you. So the other question that we have is how we label sclerotic tissue in epileptic mice. So how we know that there is hippocampal sclerosis, in other words, and that is one part of the question.
Yeah, I would say in the intramedullary acid model, for instance, what we see the neuronal death that we have, we do staining for fluorogade B. We do a NEW-N and normal staining to really see microglial activation, for instance, IBO1, CD11B markers, also astrocytes, GFAP, so to really understand a little bit more what is going on the tissue, but there are a few markers that you can see. I would say that hippocampus is going to be sclerotic. That's a little bit like, I would say, I would not extrapolate that far at 24 hours after status epilepticus. Yeah. So what we see is a neuronal death in that sense. So that would be, I would say, trying to mimic some of the damage that we have.
So you mentioned considerations about the age of the mice. So what is considered an old age in a mouse, generally?
Yeah, well, the lifespan of a mouse, if I'm not mistaken, is a bit more of about 1 year old or something like that. So I would say that this is an important point, and sometimes you see a lot of research that is done with mice in 5-6 weeks, and they are actually teenagers in that age. It's okay, but we need actually to try to understand a little bit more the lifespan and try to stratify a little bit more in our experiments. So I would say that the mice, usually in a general way, if I want young adults, I'm focusing on about 12 weeks. And then as you progress from that, but I worked with mice, from 6 months, 9 months, and then you can clearly see that there is differences in neurophysiological differences and behavioral sometimes, depending on the strain, because this is very variable what you're going to find. But again, you have to characterize depending on what you're looking for. But I think it's important to consider, especially because epilepsy, we can have the development at any age.
Yeah. So the other question is that sometimes it's hard to reproduce results for treatment of models of epileptogenesis. So people are wondering, what do you think are the more promising approaches or ways to probably address non-reproducible results, for instance?
Sorry, Christos, again.
So sometimes there is a lack of reproducibility for treatments in different models, and what do you think are the most promising approaches to actually increase the reproducibility of results or replicability, possibly?
Yeah, I think that's a very important point. I think, one of the tools that we have is open science. I think sharing data is extremely important. I think designing the experiments very well is extremely important. I think we need to spend more time thinking about our experimental design. I think this brings reproducibility. Things that I always took in my research that now comes as a kind of very good thing is time of the day. When you're doing in vivo research, that's crucial. And that's something that I was always very boring since my early training times, that I would kind of do the surgeries at the same time of the day, collect the samples at the same time of the day, and I would have low variability. And that increases reproducibility. And now, investigating the circadian rhythms impact on the brain, we see that 80% of the transcriptome is varying over 24 hours, and we have non-coding varying over 24 hours, for instance. So if you take samples in different times of the day, that is going to impact your experiments. So I think like a very well designed and a very well controlled experiment to make sure that each batch of experiment is going to be well represented and having this internal reproducibility. I think that's the first step, but it's just really trying to minimize the bias and
So the other question is about cognitive impairment, because it's a comorbidity. Epilepsy has many comorbidities, and people that are excited to test new approaches for treating comorbidities. Is there a model that can be used for that? And is it better to be used in rats, mice?
Well, I'm going to be honest, I'm not an expert in behavior. I would say that there are people that are way more experts and looking at specifically at behavior. And that's a very, very important field itself, not only looking as comorbidity of epilepsy, but there are a number of very good articles that cover those traits. I think like there are a number of models a number of tests that can be done. I think like thinking, when thinking as comorbidity and merging with the experiments in epilepsy, if I can comment on that perspective, I would say my experience is extremely important that you see when you're going to do the interventions for the behavior, because any intervention that you're going to do, prior to behavior could impact your behavior experiments. So it really, again, depends on your question. So if you need to do the behavior, wait the right time between interventions. So this is another key aspect for that. But I would say I would not be the best person to actually focus and answer in depth about the cognition.
Thank you for that. So one question that I have is that, so you mentioned that the different models can use either mice or rats. If, for instance, somebody has a model that is in mouse and wants to go to the rat, or from the rat to the mouse, what do you think is some of the major considerations? For instance, let's say the PTZ model, is it just the dose that they need to think about, or it's something else when you switch, species?
I think it's extremely important. Another important point that we need to discuss, because, we have to remember that mice, they are not small rats. So they are a completely different species. And what you have in one may be completely different for the other species, so not necessarily are going to reproduce. So yes, it's really important to understand and to validate your model again. So if you have in the lab already established a model, for instance, pentylentetrazole in rats, and you would like to start working with mice, you are not going to be able to just extrapolate exactly what you have, but you have to establish the model again from scratch and really understand and ensure that you have the model standardized. So it's not going to be only the phenotype. If you change the strains, and I had experience before with mice from different background strains, like if you're looking at kind of black C57 mice and you're looking about SV129 and you're looking about Swiss mice, they have large differences in their behavior and their normal behavior. So that could definitely impact the model, that definitely could impact for instance, if you're measuring Racine scale, that could have differences there. So these differences need to be accounted when you're planning. So I strongly believe that the model needs to be, reassessed and re-standardized. So that increases the validity, the reliability of the experiments, and likely the reproducibility.
Very important point. And I think one last question that I have is about the study using midazolam to curtail seizures during status. So essentially, we want the mice to have epilepsy, but all of us, we give them anti-epileptic drugs after status epilepticus, which, usually might not happen in the real world. And we are trying to have the mice to have seizures, but we give them a drug. So, and of course, you know, that relates to minimization of stress and you know, all of these things. But I was thinking if you know, could comment on, you know, the use of those drugs during the initial insult and why we use them and how they may affect outcomes.
Yeah, I think that's an important point. I think like we have to start from the idea that if that is not a variable in your study, for instance, if you're not interested in knowing what's the effect of midazolam or lorazepam or any other drug in your study, that needs to be administered exactly the same way to all the animals. So that's not going to theoretically, you know, impact. So all the groups are exposed to the same I would say conditions. So I think like it's getting more and more common because of the refinements that we need to do in animal research, that we're going to be administering a number of drugs here. Lorazepam, midazolam in the case of this study that's used to reduce morbidity and mortality. In our hands, intramidolacanic acid, we see if we don't give lorazepam, they will increase mortality, and we must do that. So we also have during surgical procedure, we look even before the administration, like during the surgical procedure, we have the use of anesthetics. If you are using, for instance, isoflurane, isoflurane itself has anticonvulsant properties. Of course, it's going to be washed, it's going to be, you know, cleared out from the body, but it's still, it's something that we have to consider the anesthetics. We have to consider if we use antibiotics, if we use anti-inflammatories, if we use other painkillers for the animals. So, and this brings the variability of the models in the labs. I don't see it as a big problem, but it's important that depending on what you use, that we standardize and you know exactly the outcome that you have. So you really need to know your model in your conditions. So I know the model with all the pre-op drugs and the post-op drugs, plus the drugs that I need to use for refinement. I know how many, how the status epilepticus should be, when it should start, how many spontaneous recurrent seizures the mice are going to have. So then you have a standard model, and then you can confidently evaluate your therapeutic. The problem is that different labs are going to have different practices, different countries are going to have different practices, and that could generate the variability that we see. So it's just important that we kind of, you know, we characterize them well when we're doing, and we discuss about these things, because they will happen.
Yeah. Another question is, you mentioned sex differences. And because you are a chronobiologist, I want your comments on, you know, you have a male mouse and you have a female mouse. Is it just, you know, this, you know, kind of the two sexes, or within the sex, if there are some hormones that they change? So my question is around not just looking at, you know, the two sexes, but within each sex, how all the hormones and, you know, the rhythms affect epileptogenesis and all the rhythms that we see for, you know, targets, for seizures, cognitive problems. So your perspective on this
That's
issue.
very good. That's a very difficult one. So first of all, a disclosure, I'm not a chronobiologist. I'm pharmacologist, but I've been working and delving, and I'm very lucky to have a chronobiologist working with me in supporting my epilepsy research. So I would say it's very important to look at, and I think like more and more it's becoming more evident the need for that, especially as we move to precise and personalized type of treatments. The differences between sex, I can speak from my own experience so far. I would say that I've seen some models that we didn't see much of a difference between sex, that they use, you know, even I always start from, even if it's like, for instance, intramidolacanic acid, I took coordinates from the brain to see, okay, is the brain exactly the same shape? How is the shape? How are the coordinates? Are the same coordinates to reach the same effect? I think these are, you know, simple things that we need to kind of, you know, to take into account. Moving from there and kind of looking at, I think like, you know, as we can synchronize, I have to say, for instance, the female mice as much as possible, that would reduce variability, because yes, I would say that they would be in different moments in their multi-diem rhythms, and this synchronization, I would say that would support. So again, using the same age, trying to match as much as possible with your controls. I think that reduces variability. But we have a whole bunch of good years and lots of young investigators coming up to support these investigations. I think that we really need to explore a lot about that, but there is definitely a lot to explore.
Of course. Thank you so much. So we don't have any other questions, and unless you have any concluding remarks or anything else, Cristina?
I would say from my side would be it. I really hope that that's useful information, and again, I really hope that everyone keeps the discussion channel open, because that's what we really need in the field.
Exactly. Great. Thank you so much, Cristina. I would like to thank you all for attending the very first Basic Science webinar. I would like to invite you to all the other webinars that are coming up. So make sure you register, make sure you follow Yes ILAE over social media, and make sure you send your questions offline. We're going to be happy to discuss and support basic science throughout this process. So thank you again. Have a great day. And that's it.
Thank you very much. Thank you very much, everyone.